the pointers which are markers for renal flare are the patient if they have low C3, increase in creatinine, high dsDNA antibody, active urinary sediment, and normal uric acid. It is a it indicates that patient have active lupus disease rather than preeclampsia. And pregnant lupus patient require frequent Doppler of uterine artery for early diastolic notch to demonstrate ischemia of the placenta and uterus. So how to manage this lupus flare and if the patient have active disease? So management of flare should take into account the need of both to control the disease activity rapidly and also to avoid the teratogenic effects of the drugs on the patient and the fetus. The drug of choice is prednisolone, which is oral. The low dose in mild to moderate disease is safe in pregnancy. Increased dose is associated with preeclampsia and gestational diabetes. Methylprednisolone pulses can be given in a severe active disease, which can sometimes lead to higher maternal complication. So we have to use the lowest possible dose to control acute flares. Hydroxychloroquine is the drug of choice. It crosses placenta, but however, no toxicity is reported, so it should be continued throughout the pregnancy. Azathioprine should be avoided because it can rarely leads to birth defects. NSAIDs can be used with caution in first and second trimester and should be avoided in last trimester. The other drugs like mycophenolate mofetil, cyclosporin should be avoided, and cyclophosphamide can be given in late second and third trimester if the patient have life-threatening flares. There are certain drugs which are called biologicals. They are not safe in pregnancy in lupus. However, and if anti-TNF, which are used by chance in some patient, can lead to ANA positivity. All drugs are secreted in breast milk in variable amount, so we have to be very cautious during lactation period. The interval of 4 hours should be maintained between breastfeeding and drug intake to minimize exposure to the fetus. However, we allow HCQS during lactation period to be continued. A rheumatologist should actively participate along with the obstetrician in managing pregnant lupus patient. Her main role is to pick up the active disease and to differentiate from the gestational complication from the SLE complication. The commonest complication which is neonatal lupus, which I will be covering later along with the Sjögren syndrome. The other association of other association, the common association along with lupus is the antiphospholipid syndrome. It is defined as an acquired prothrombotic state characterized by presence of one or more antiphospholipid antibodies, mainly anticardiolipin antibody or lupus anticoagulant, plus one of the clinical manifestation, namely arterial thrombosis, venous thrombosis, and recurrent fetal loss at 10 or more weeks, along with thrombocytopenia and autoimmune hemolytic anemia. A moderate, which is 20 to 80 to high titer, which is more than 80 GPL, represent the high positive value. A moderate to high GPL, if present for more than one occasion of at least 2 weeks apart, is more specific for diagnosis of APS. APL is found with increased frequency in lupus patient. It can also be associated in many other autoimmune diseases, ITP, and certain infections and drugs. I will be covering in short the management of APLA in pregnancy. If there is no past pregnancy morbidity, no treatment or low dose aspirin with or without hydroxychloroquine should be given. If there is only one early first trimester loss, low dose aspirin is allowed. If patient have multiple early losses or one late loss, prophylactic heparin plus low dose aspirin is given. If a patient have history of past venous or arterial thrombosis, therapeutic anticoagulation with heparin with or without low dose aspirin is given. If patient have active lupus, steroid pulses along with the anticoagulants are given. Now we come to case two. A young female presented with a history of 4 weeks of pregnancy, along with mild joint pain, especially of small joints of hand. And she also had a history of rashes in the lower limb in the past. On further inquiry, she said that she had dryness of eyes and mouth since past 2 years. And once she also had swelling over her right parotid 1 year back, which had subsided within few days with use of NSAIDs. So she was investigated, and her investigation revealed hemoglobin of 11 gram person, counts of 6.6, platelet 3.5. Her ESR was 40, and her ANA was ordered, which showed 1 is to 162 plus in speckled pattern, and her anti-Rho and anti-La antibody was positive. Her shimmer test was done, which is like we put a blotting paper in the lower lid of the eye to see for the tear formation. So her shimmer test was done, which was 2 millimeter in 5 minutes, which is positive. It means that there is no tear formation in her eyes. So diagnosis of Sjogren's with pregnancy was made. So along with the drug treatment, her fetal Doppler was ordered, which was started at the 18th week of gestation, which was done initially every 15 days till 28th week, and which was normal throughout her gestation period. She was started with HCQS 400 milligrams once at night for 2 months, and then it was tapered to 200 milligrams once at night throughout her pregnancy, along with the calcium and vitamin D supplements. She was also given NSAIDs for initial 2 weeks to relieve her symptoms. She delivered at term through cesarean section, and she had a healthy baby with no evidence of any skin rash or heart block. So, what is Sjogren syndrome? It is an autoimmune disease which can present either alone as an in primary Sjogren syndrome, or it is associated with an underlying connective tissue disease, most commonly rheumatoid or lupus. The spectrum of clinical presentation of Sjogren syndrome extends from dryness of male mucosal surface to systemic involvement. Dryness of mucosal surface like dryness of eyes, dryness of mouth, or vaginal dryness occur because of immune mediated inflammation causing secretory gland dysfunction. Sjogren syndrome is one of the most common autoimmune disease. A reported prevalence is between 0.1 and to 4.8% in various population. It may occur at any age, but affects mainly women at the fourth decade of life. The female to male ratio is estimated to be 9 is to 1.8. The increasing frequency rate of pregnancies in women with primary Sjogren, and hence the increased impact of disease on pregnancies. The histologic hallmark of disease is the focal lymphocytic infiltration of the exocrine gland. The laboratory diagnosis of Sjogren syndrome is usually made by the following markers. Like if we do the ANA is positive in speckle pattern. Patient can be positive for anti-Rho or anti-SSA antibody and anti-La or anti-SSB antibodies. Sometime one is able to demonstrate the cryoglobins and hypo complementemia, which indicates they are the main prognostic. They have main prognostic markers because they can point a severe or bad disease. These markers mediate the tissue damage and are thus responsible for complication in pregnancies of women with Sjogren syndrome. Antibodies start crossing placenta beginning at approximately 12 weeks of gestation and may exert the following effects on the fetal tissue. It can lead to carditis, and it can the binding apoptotic cells can block presumed physiological clearance and divert clearance to macrophages, which can produce arrhythmias and conduction heart blocks. So effect of Sjogren on pregnancy are the preterm birth, low birth weight, IUGR, and increased incidence of cesarean section. Now we come to what is called neonatal lupus. So neonatal lupus present as a congenital heart block or as a lupus rash. It is associated with maternal anti-Rho and anti-La antibodies. Anti-Ro and anti-La antibodies begin to cross placenta at 11th week of gestation. The reported prevalence of complete heart block in the offspring of an anti-SSA positive woman is 1 to 2%. The recurrence rate in a patient with antibodies who has previous child affected is approximately 10 times higher. The peak incidence of detection of complete heart block is at 20 to 24th week of gestation. Therefore, fetal echo Doppler can be used to determine the mechanical PR prolongation, which usually we start from 16th week to 28th week of gestation. There is only 2% risk of congenital heart block in pregnancy in patient with anti-Ro and anti-La antibodies. So prophylactic therapy is not currently recommended. Most babies with congenital heart block can be delivered at terms. If there is severe heart drops, early cesarean section is necessary. The rash in neonatal lupus is a photosensitive. It is usually transient rash which occurs on the abdomen of the fetus and it resolves without scar. The risk that newborn will have a rash is only is 25%. The rash generally doesn't require treatment and it disappears spontaneously in few weeks' time. So management of neonatal lupus is prenatal management and antenatal management. In prenatal management, it is the counseling is very important. A pregnancy should be a planned pregnancy because we have to discuss with the patient about the risk and complication involved in the pregnancy and also certain medication which are contraindicated in pregnancy. So ideally, it should be a planned pregnancy when the disease is very well controlled prior to 6 months before the conception. During antenatal management, frequent surveillance by fetal echo between 16 to 20 weeks of gestation and thereafter is required for at-risk pregnancies. The goals are early diagnosis and early treatment of incomplete heart block, thus improving the outcome of the fetus. The rationale for management are is to decrease the maternal autoantibodies and then to decrease their placental transfer, to decrease the inflammation once it occurs because it leads to permanent fibrosis and irreversible complete heart block. So treatment is fluorinated steroids like dexamethasone or betamethasone. It can reduce the antibody-mediated inflammatory damage of nodal tissue. Dexamethasone treatment is recommended if the block is recent or incomplete, or if there is evidence of cardiac failure. Maternal risk of fluorinated steroids include infection, osteoporosis in female, osteonecrosis, and glucose intolerance. Specific fetal risks include intrauterine growth restriction, oligohydramnios, and possibly adrenal suppression. So alternative therapies, if the can be tried in females like plasmapheresis or intravenous IVIGs, but they don't have. They can be tried, but there is no evidence that they are really helpful for prevention of complete heart block. In most cases, complete heart block requires a pacemaker implantation in the infant, preferably in the neonatal period. So take home message is ideally pregnancy should be a planned pregnancy in a patient of a lupus or Sjogren's disease should be in remission for at least 6 months prior to pregnancy. Pre-pregnancy screening for Ro, La, APLA, and markers of disease activity is must. Women with Sjogren's are likely to experience more complication during pregnancies. Studies had showed a high incidence of poor fetal outcome for these patients. So a high-risk pregnancy should be optimally managed by a multidisciplinary approach involving a high-risk gynecologist, a rheumatologist, and a pediatrician. Thank you for your patience listening. I'm happy to take questions.
Thanks, Dr. Priyanka. That was really elaborate information that you have given through your scientific deliberation. Definitely, all pregnancies, all patients with SLE and Sjögren should have a planned pregnancy, and the disease should be questioned for at least 6 months prior to conception. Because if there is an active disease at the time of conception, that definitely leads to adverse maternal obstetrical outcome. Preconception assessment is essential in women with SLE to determine whether the pregnancy may pose an unacceptably high maternal or fetal risk. We know higher rates of complications such as preeclampsia, preterm birth, fetal loss, growth restriction, and neonatal lupus syndrome can seen if the patient is having active disease. And we know that HCQ can be given during the pregnancy and it reduces the risk of SLE flares. Besides, we also know that women with risk factors or poor prognostic indicators may require more frequent maternal and fetal monitoring. The treatment of active SLE during pregnancy is guided by the severity and degree of organ involvement, similar to patients in the non-pregnant state. And treatment definitely should be in collaboration with gynecologist, rheumatologist, as well as neonatologist. And we know SLE can occur in a younger patients, so infertility is not an issue. These patients do get pregnant and we do get them in a clinical practice. Women with Sjögren syndrome are likely to experience more complications during pregnancy than patients with SLE. They have a higher incidence of poor fetal outcome for these patients, and women with this underlying autoimmune disorder must undergo prenatal counseling, and we must explain to them the risk involved and the need to control the disease before conception. And as you all know, these high-risk pregnancies has to be optimally managed by multidisciplinary approach involving a high-risk obstetrician, rheumatologist, and a pediatrician. Again, I must congratulate Madam Dr. Mehra because she thought of this innovative approach and she conducted this CME together with a rheumatologist. We are dealing with high-risk pregnancy in our day-to-day practice, and I'm sure all the obstetricians who are attending will get benefit from today's deliberation, and will definitely our patients will benefit in longer run. Thanks, Madam, for allowing me to be a part of this CME.
Thank you, Dr. Mala. And thanks, Dr. Kharbanda, for enlightening us with a newer topic of this SLE in pregnancy. Really, I think you must have come across in COVID time with HCQ.
Yeah.
HCQ must have been given in March and April. By now, the results must have come. Those patients who were given HCQ, how the babies came out. Neonatal. Do you have it?
By and large,
because in your hospital, COVID deliveries were there.
HCQs is known to prevent the flares. That's what we know, Dr. Priyanka. It prevents the flare.
Ma'am, hydroxychloroquine is the anchor drug to control the disease activity, and it is the safest drug, although it causes placenta, but there is no fetal toxicity, or so it should be continued throughout the pregnancy to control disease activity. So because if disease is active, the chances of abortions and the further complication of pregnancy is more. So if you want healthy baby, healthy pregnancy, everything to be good, hydroxychloroquine should be continued in a lupus patient and Sjögren patient.
And sometimes in Sjögren, we give steroids. There is some apprehension about giving steroids in the first trimester.
Yeah, ma'am, we only give steroids in low to moderate doses, which is up to 10 milligram per day. If the patient is bad, like if the patient is having very bad joint pains and her disease is not controlled along with the hydroxychloroquine, so we give it for a short time and taper and stop it fast so that the exposure.
And Dr. Priyanka, is it given in the divided doses? Divided doses should
No, ma'am. No, ma'am. It should be given once in the morning. It should not be given in the, because we are giving very less dose. We are not giving high dose. Okay. So preferably at 6 o'clock early in the morning, it should be given. If not 6, it should be before 8.
Okay.
Because then it merges with the physiological steroid what we get in our body. So if we are not using very high dose, we are using only up to 10 milligrams. So one dose early in the morning is good enough.
Even if the disease in the quiescent state, Do we need to give steroids in the first trimester?
No, no, not at all. Not at all. In a quiescent state, there is no need to give steroids. Rather, I also, if the patient is really inactive, I stop hydroxychloroquine for the first 3 months, because that time fetus is forming and after that it is only growing. So why to, if possible, if the patient is really in a good state, there is no disease activity, I even stop hydroxychloroquine at this time, so that the fetus is not exposed to any of the drug. But the recommendation is to that we should be continuing. But in clinical practice, if the, like, patient have a lot of apprehension, so if the patient is doing good, I always stop hydroxychloroquine as well during the first trimester.
So the patient is having low disease or quiescent phase 6 months before the pregnancy, then definitely they benefit.
Yeah, it should always be a planned pregnancy.
Yeah. So pre-pregnancy counseling is very important.
Very important, very, very important.
And they should enter a pregnancy after counseling with a physician.
Yeah, ma'am, once the lupus patient comes to us, it's always of our, we make a routine questioning that are they planning pregnancy in near future? Because we have to decide our medicine as per their future plans, and we always convince them that they should not get pregnant during this active disease, because that we convince them, we counsel them that at least your parameters like ESR, CRP all should be normal, and you have no clinically active lesion, then only you plan for a pregnancy. So if patients are with us, they generally plan the pregnancy in their inactive phase. But sometimes the patient come to us for the first time with the pregnancy itself. That time, then it's a difficult to manage them.
Yes, definitely. Your lecture was really an eye-opener. And we learned quite a few things today.
Thank you, ma'am.
There is one question from Dr. Tarun Sharma, how to diagnose and manage lupus in pregnancy. I think he must have heard the whole lecture. So it was very well told by Dr. Priyanka. Dr. Tarun Sharma, if you have not attended earlier, so please go for the recording. This will be available on YouTube. Okay, any other question, Mr. Dinesh? Any other question from audience?
As of now, only that one question, ma'am, I got in the queries link.
Okay, that has been answered. Okay. And you will be putting the recording on YouTube?
Yes, ma'am. We are having the recording on our computer and both in YouTube also, ma'am.
Yes, you can.
Yeah, so, ma'am, and one thing, if Priyanka ma'am completed the sharing, can he off the screen share?
And off the screen, Priyanka, Dr. Priyanka?
Yeah, ma'am.
Okay.
Dr. Priyanka, please.
Yeah, ma'am, I'm doing that.
I think you went very well.
Ma'am, Dr. Ashwini is there. You have to call him.
Yes, Dr. Ashwini is there. So let her off her screen.
Priyanka ma'am, please stop screen share option. Press on the stop screen share option.
Yeah, just a minute.
In the Zoom window.
Yeah.
Actually, it's my pleasure to introduce Dr. Ashwini Dalmia. Dr. Ashwini Dalmia, can you hear me?
Yes, ma'am. Thank you very much. Good evening, all.
So he has been the past 3 times State Secretary, Senior Vice President of DMA, National Joint Secretary, and presently he is Secretary MEMCOS, Secretary IMS Central, Member Executive DMC. So please welcome Dr. Ashwini Dalmia.
Thank you, ma'am. Thank you.
My motto, you must be knowing that he is contesting for DMA election for president in 2021. So elections are due on 28th March. So Dr.
Ma'am, it is on 4th of April.
4th of April. So आप हमारे लिए क्या करोगे?
मैम, मैं पहले ये बताना चाहूंगा कि मैंने क्या किया।
हम तो वैसे ही करते हैं ना जैसे जनता पूछती है।
नहीं, बिल्कुल ठीक है मैम, और मुझे लगता है पूछने का अधिकार भी और पूछना चाहिए भी। And I must acknowledge the presence of Dr. Mala Srivastava. She is not aware, but Dr. Srivastava is a very good friend. He's like my elder brother. He might have told you as well. And Dr. Priyanka, it was a very nice talk, though I joined little later. Ma'am, what I have done, I joined Delhi Medical Association in 2000 and I became state secretary in 2008. And this anti-violence law, which was given by government led by Sheila Dikshit, was because of our effort. That was one thing. Another thing is nursing homes, daily nursing homes and clinics were stopped to function by High Court order. That was writ petition 4233 by 1993. A special leave petition was filed in Supreme Court of India, and the decision was stayed during my tenure as state secretary in 2009. And before coming to other issues of DMA, I would like to apprise you that as member of disciplinary committee of Delhi Medical Council in 2019-20, not a single doctor was punished in Delhi Medical Council disciplinary committee. And I on record recommended that false and frivolous complainant must be filed some sort of actions or FIR against them so that our doctors should not be harassed, because majority of complaints are either against surgeons or gynecologists. And I recommended in first executive committee meeting as executive member of council that all the experts which decide the negligence cases are from government sector. We strongly recommend that there should be two experts, one from private sector, another should be from government sector, because the constraint and limitation of private sectors cannot be appreciated by people who are working in government sector. Anything else, ma'am? I think I have done my job.
Yes. You are the most eligible candidate working for DMA for such a long time.
Thank you,
I don't think so you need any introduction. And our next candidate is for Vice President Dr. Lekhi. See, Dr. Neelam Lekhi is Senior Consultant Radiologist, alumni of Agra, Chairperson Delhi Women Doctors Wing, immediate past National Chairperson IMA Mission Pink Health, first female President IMA East Delhi Branch, Chairperson Women Doctors Welfare Association, Central Council Member, DMA Executive Member, past Vice President IMA East Delhi. Please welcome Dr. Neelam Lekhi. And Dr. Neelam Lekhi, my heartiest congratulations to go for election. Any female has come forward for DMA.
Thank you so much, ma'am. It's pleasure to be on your platform.
Winning and losing is another this thing.
Yes, ma'am. And first of all, I like to thank you for having me at your platform. You, Dr. Mala Srivastava, Dr. Kharbanda, and all the elite ladies who are working so nicely for years together. And I know since we have conducted first women conference in DMA, and then we were actively participated in that, and we were connected at that level. Sir, ma'am, since then I am working for at every level, at branch level, at state level, and at national level, for the welfare of the society, our medical fraternity, and for women doctors as well. And my number one motto is to increase the participation of women doctors at IMA level, because our representation, and now the representation has increased in our branch also. When I became the first female president of women of branch, no women doctors was ready to come. Now at least after that 2 women have contested for the president, and number of women are in line to become the president now. So at branch level also, and at state level also, and at national level, I was national chairperson of Mission Pink Health, and under that, I have constituted Mission Pink in 22 states of the country, and under which we have covered around 6.5 lakhs of adolescent girls in all over the country for anemia-free India, and for menstrual hygiene awareness, good touch, bad touch awareness, and number of projects. And at branch level also, when I was president, I made 650 life members at concessional rate in my branch. That was record membership and in East Delhi branch or in any branch of the Delhi in a single year. So many life members were added during my tenure. I have conducted 4 major conferences in my branch during my tenure. So I have done so many work, but the thing is, wherever I want this opportunity to be in DMA, if you feel I'm eligible, wherever, whenever you will need me at any point of time, I will be readily available to all of you, and especially for our women cadre. I want all of you should be active in DMA, IMA also, because they are doctors and especially gynecologists are facing lot of problems. So we need to have our voice at DMA. So I want, and our team want, as you know, Dr. Dalmia has also worked so much. So our team want your wholehearted support, ma'am. Thank you so much.
We are always to support you, but we want the biggest nuisance of these days. हमारी पिटाई से हमें बचाओ.
Exactly, ma'am. Ma'am, and when I was president, I made quick response team, ma'am, during my tenure. And
the moment you touch the patient, ऐसा लगता है अब ये हमसे लेके जाएगा कि हमें देके जाएगा.
बिल्कुल, बिल्कुल, ma'am. That's why very much necessary कि we should make the quick response team. And उसमें क्या है कि nearby area में जो भी आपके डॉक्टर्स हैं उसमें वो immediately, if you are in trouble, तो immediately 10-20 doctors should reach there. अगर आपके वहां पे 10-20 डॉक्टर्स विद इन 5 minutes और 10 minutes वहां पहुंच जाते हैं मैम, तो कोई डॉक्टर जो फीमेल अटेंडेंस है वो इतना डेयर नहीं कर पाते हैं आप लोग उसके लिए. और बाकी सेंट्रल लॉ के लिए हम लोग ने बहुत कोशिश कर रहे हैं, इवन IMA लेवल पे भी और डिस्ट्रिक्ट स्टेट लेवल पे भी. तो मैम इसके लिए डेफिनेटली वी विल वर्क हार्ड along with Dr. Ashni Dalmia. As you know, he is very dedicated person for the community. तो हम लोग चाहेंगे कि इसको हम सेंट्रल लेवल पे इसको पास करा पाए और इसको अवेयरनेस लोगों में क्रिएट कर पाए. इवन कभी अभी जैसे केसेस होते हैं तो काफी जगहों पे लोगों को पता भी नहीं है कि ये लॉ एग्जिस्ट करता है, तो ये अवेयरनेस क्रिएट कराना भी बहुत जरूरी है. तो वी विल डेफिनेटली वर्क फॉर दैट.
Okay, Dr. Neelam Lekhi, thank you very much. We hope for the best,
both of you.
All the best to both of you.
Thank you, ma'am. Thank you.
Okay.
So much. Thank you for having us here at your platform. Thank you so much.
And thank you once again, the Hetero Healthcare, Mr. Ravi Kumar. Can you, Mr. Ravi Kumar? Mr. Ravi?
Yeah, ma'am. Good evening.
Yes.
Good evening, ma'am. Yes.
Thank you very much for giving us the opportunity to
My
conduct.
pleasure, ma'am. Thank you very much for giving us opportunity, ma'am, to associate with you. Thanks a lot, ma'am.
Thank you. Thank you.
Thank you, ma'am. Thank you once again.
Thank you.
Thank you so
Thank
much.
you. Thank you, ma'am. Thank you. Thanks a lot.
Okay. Can we
Thank
continue?
you all.
Thank you.
Okay.
Bye bye, ma'am.
Bye. Bye, ma'am. फिर मिलते हैं.
फिर मिलेंगे.
फिर मिलते हैं. Okay. Dinesh, can we quit? Dinesh?
Ma'am, if you completed, can I stop the go live and the meeting?
Yeah, yeah. Yeah.
Yeah, okay, ma'am. I am stopping the go live and meeting also, ma'am.
Thank you so much.
Thank you, ma'am. Thank you very much, ma'am.
Uninterrupted meeting. Okay. Bye.
Thank you, ma'am.